Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you all can hear my voice clearly. So once again, this is Dr. Anita Sargent, your MC for the session. If you wish to claim your certificate for the same, kindly visit our website, which is www.onlinedentistry.in/9 p.m. and register for the same. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. The motto we preach is to redefine dental education. It has been over 14 years that online dentistry have been conducting sessions for clinical practitioners across the globe. Established in the year 2008, so far we have covered over 203 offline courses and have conducted 1,022 online courses with an enormous amount of more than 30,000 followers on our platform. Let me proudly introduce the CEO of online dentistry, Dr. Binuti Abraham, who is one of the finest practitioners in town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Aluva. Currently, he's interested in educating thousands of clinical practitioners through online and offline sessions. Moving on to the academic head of online dentistry, Professor Dr. Joby Peter. Currently, he is the HOD of Department of Pediatric Dentistry at Anu Dental College, who preaches the philosophy to catch them young and watch them grow. Over the years, we have grown dynamically, launching 10 centers in different parts of India. The latest addition to our courses, the one-year comprehensive course on interceptive and myofunctional orthodontics, have been successfully initiated with 2 batches, and now we are open to take up students for the 3rd batch coming up in September 2023. This is a multidisciplinary approach with intense training and hands-on session under the team of eminent faculties, including our own Professor Dr. Joby Peter, Dr. Binuti Abraham, Dr. Monica Sharma, Dr. Shine Shukur, and Ms. Sahana. The registrations have started for the next batch, which commences on 22nd, 23rd, and 24th of September. We are happy to announce that we have only 2 more seats remaining. Another feather to our cap, our 3-day program is about to commence on the 28th, 29th, and 30th of April at Cochin, which will be an amazing workshop on interceptive and myofunctional orthodontics. We are again happy to announce that we have only 2 more seats remaining. Thank you all for your overwhelming response. You can always feel free to reach to us on our WhatsApp numbers and visit our website, which is www.onlinedentistry.in, or else you can mail us on onlinedentistry.in@gmail.com. Online dentistry have been conducting sessions all over India for the past 14 years. During the lockdown, we started conducting online sessions to benefit the practitioners, which have been received with great appreciation from the dental fraternity. In the year 2023, we are relaunching the same by providing free advanced learning series under the title Online Dentistry at 9 p.m. We'll be coming up with another amazing session on 10 reasons why you should be doing porcelain laminate veneer by Dr. George Jacob. Without further ado, let me move on to introducing the speaker for the day. Dr. Pravish, MDS. He's a consultant maxillofacial surgeon. Sir completed his BDS from JSS Dental College in the year 2009. He secured his PG in OMFS from GDC Kozhikode. He's currently working as the Associate Professor at Sri Anjaneya Dental College. He was also the faculty for oral surgery at GS Scientia Platform, Dubai. His fields of interest are minor oral surgery, cysts and benign tumors of orofacial region, maxillofacial trauma, cosmetic facial surgery, orthodontic surgery, and dental implants. Sir, we proudly welcome you to online dentistry, and the session is all yours.
Thank you, Doctor. So, good evening, all. I would like to see some faces. I think if you can show your videos, I can at least see some faces, and we can have an interactive session. I hope my audio and my slides are clear.
Yes, sir. Yes, sir.
Yes. So, good evening, all. So, we will be discussing a few things about wisdom tooth removal. The topic, I've kept it very clinically oriented, and any doubts is there, you may please message and you can ask the moderator, and at the end of the session, we can have a discussion on it. Okay. So let's start with the topic. I've named it as extract the wisdom tooth removal simplified. So I'll be dealing with some tips and tricks and how to diagnose, how to do, or how to plan your treatment, and a few very common complications. Okay. So let's keep it very simple. When you call the teeth impacted, when we call the teeth impacted, you can actually message through the chat box. So let me keep it very simple. Is the slide which I have shown, or is the photo OPG which I have shown showing you an impacted teeth? Anyone can you just message in the chat box? Is it showing the impacted teeth or not? Yes, no. Yes, I'm getting some mixed reviews. Some of them are saying yes, some of them are saying no. I would like to have some more of the response. Yes, there are many for no. So why is it no? A teeth is said to be impacted only when it has not come out of its it has not come, or it has not erupted even after its formation of root. So I'll just show you another OPG. Now this teeth are impacted. Why? The roots are formed and still it has not come out. So probably the first radiograph which I showed you, the age of the patient is probably somewhere between 15 or 12 and 15. You know, the permanent teeth has come, but the third molars have not yet started forming, or the roots have not yet started forming. So only when the roots form, the teeth comes out. So these kind of teeth cannot be said impacted unless and until it the root actually develops more. So the common impacted ones or impactions which we deal with are the third molars. Apart from third molars, there are other teeth like your canines, your premolars, and any other teeth. Even a central incisor can get impacted. So the general definition which we were, or general thing which we were talking about was impaction or impacted teeth is something which has not come out even after the root formation is completed. Now coming to various theories of impaction, you know, some say that it is due to some obstruction due to some cyst, tumor, obstruction due to some teeth. I mean, if it's not a wisdom teeth, if it is a central incisor or lateral incisor or premolars which is impacted, it can be due to a retained deciduous. But when it comes to your wisdom teeth, the evolution says that you used to have jaws like this. You know, we used to have big jaws, and now all of a sudden this jaws have become small, and it has evolved to this phase. The jaws have become small, but the teeth is still big. So the teeth sometimes might not have space within the jaw. So any theory which talks about impaction just says that there is a size discrepancy. The teeth cannot erupt in the smaller jaw. So where does the term wisdom come from? Probably the term wisdom is used because this teeth comes in the late teenage. So the person is entering into 20 years or 21 years. So probably that's when they say that, you have attained wisdom, you have finished your college, or, you have entered the college. So that's where the term wisdom comes from. So don't worry, when you remove a wisdom teeth, your wisdom doesn't go. It's just a term they used. And now it's impacted. So what? Any teeth, it's impacted. Do we have to remove each and every teeth? Yes or no? How many for extraction? How many here for extraction? So it's an impacted teeth, extracted. How many are there supporting extraction? Can I see some answers in the chat box, please? Quickly. How many for yes? Yes, many are for no, only if symptomatic. Yes. Any others? Okay. Most of you are no. Depends on age, if any pathology is present. Not at all. Okay. So majority here are for wait and watch, isn't it? Now that's a very good policy. That's a very good policy. You don't have to take out impacted teeth. But let me just clear some concepts. There is something called as prophylactic extraction of third molars. So some countries do advise to do prophylactic extraction of possible impactions, they say. So if the teeth may, or in future, if it may go for an impaction, you can actually remove it. That's one school of thought. But majority follow wait and watch. So if it is not symptomatic, you don't have to do anything. So then when and why to remove the impacted teeth? Now impaction is like this small kitten, it is lying there, it's not causing any trouble. As far as it's not causing any trouble, it's a very lovable thing. It is not it's not going to cause any harm to you. It's just staying with you in your home. Maybe sometimes it's lying on your bed. So once the day when it starts making some trouble in your home, like the kitten has it has paws, it's going to it's going to tear your clothes, it's going to make the area dirty. If some problem is there, what you say is, you take it outside. You don't let it enter into your room. Similarly, till the day impaction is creating problems, it is like this kitten, it's silent, it's just staying there, it is not doing anything. Yeah, you can be very compassionate towards your third molar. You don't need to extract it. But yes, now start looking for the problems associated.
Dear doctors, there seems to be a net issue with sir. The session will resume soon.
Yes, sorry about that. Some connectivity issue. Just share my screen. Yes. Yeah, I hope my audio is clear. My screen is being shared.
Yes, yes.
All good? Yes. Okay, sorry about that, some connectivity issue. Okay, now look for some problems associated. What actually are you supposed to look? Now, this is the most common thing which you will get, that is pericoronitis. Next one is, can anyone find out what problem is associated with this particular X-ray? Can you tell me what is the problem associated there? I've just marked it. Yes, dental decay in 7. You know, having a caries in 8 is okay. 8 is wisdom teeth. It's okay. But getting a caries in your second molar is like, it's too bad. You know, you might even lose the second molar also. So the problem you should identify is food impaction. If at all food impaction is there, don't wait for anything, just remove it, because it is eventually going to create problem. Another one is pathologies. You know, sometimes you take routine X-ray and you find a cyst like this. And do you people know that, you know, dentigerous cyst associated with third molars, the lining has a high potential to get transformed into amyloblastoma. So you don't want to have such things, you know, bad things happening to the patient. So get it removed immediately. And another thing is, you know, another common problem is, look at the crowding which is happening in the anterior aspect due to the erupting third molar. So it may give force to the anterior teeth, the teeth anterior to the third molar, and it may cause crowding. So such kind of problems. Sometimes, you know, not all the problems will have some symptoms. Sometimes you'll have to find it through X-rays. See, only symptomatic problem was operculum, the inflamed operculum, that is pericoronitis. Rest all, you know, might be incidental findings, or the only symptom might be just food impaction, and there might not be pain or anything. So you need to further check with X-rays. So that's one thing. And in your third molars, I would always suggest, you know, you have doubt, to take X-ray. Even if patient is not symptomatic at all, take an X-ray and keep. Why? Because later, maybe probably after 1 year, 2 years, if he is having any symptom, you will have a reference X-ray which you can compare with the next X-ray you have taken. So look for problems associated. So clinically, you have to look for pericornal flap, any pockets, caries, swelling. Whereas radiographically, what you have to assess. Now, this is very important because many people don't know if you know, you have tried to take an X-ray and you have tried to evaluate, but you don't know what to evaluate, or you don't know what actually to look at. So in case if there is widening of the follicle, so we will see this what is follicle and all in coming X-rays. In case if there is widening of follicle, that is suggestive that there was some inflammation there. It can be due to the pericoronal area getting irritated, or it can be due to some cystic changes. So that is one indication. Caries, you know, any caries, even if it is minor, initial caries, also get the teeth removed. You know, it can progress. Periapical radiolucence, yes, there is some periapical changes. Yes, you have to. Pressure effect on adjacent teeth. Okay, now let's see few of these radiographic things. And the common problem is, you know, impacted teeth is coming out, and there will be an inflamed pericoronal flap. So if there is an inflamed pericoronal flap, only thing you have to do is you have to give local anesthetic first, do a gentle debridement. Just a second. Has the annotations been switched off? Can you just check, please? Yeah, can you please on it for me? So first thing you have to look for is how much is the inflammation in the pericornal region, and the probable cause for inflammation might be some food entering into that operculum or entering below the soft tissue. Now, if it is the cause, or if that is the irritation factor, then first thing you have to do is you have to gently debride it. So how to do gentle debridement? You can give local anesthesia. You have to give mostly, you know, you give a local infiltration because it's very painful. local infiltration, then you can start debriding it with normal saline. You can get saline and you can irrigate the area. And if you can use chlorhexidine also, it's fine. Then some cases you may have to give a small nick, an incision, to establish a drainage if there is pus, or you can just use a periosteal elevator and just probe it inside the flap and the pus will be discharged. Then you have to start with analgesics and antibiotics. So, Joe, I'm not able to get annotations yet. Is it on?
Disabled it due to security purposes, sir. Sir, is it possible for you to use the annotations option in PowerPoint itself, sir?
Okay, PowerPoint, I think I can do. One second.
Thank you, sir.
I'll see. I'll check. Yes, I can use it here. 1 second. So this is the thing which I was talking about. First, you give a local anesthetic. Gentle debridement. Debridement means you should this is the inflamed this is your inflamed tissue, and you should put a syringe inside the inflamed tissue and flush out any debris there. Okay. And then finally analgesic and antibiotics, normal moxiclav or antibiotics analgesic like methalfort would be more than enough. Okay. But you have to do the debridement first. Okay. Without debridement, it is not of much use. So give local anesthesia, debride. Now, what type of X-rays do you need for impaction? IOPA, is it enough? Yes or no? How many for enough? How many for not enough? How many for enough? This picture is enough. This one which I've shown you now. No, not enough. As long as the periapical area is not clear, it's not enough. I'll tell you why. Because sometimes you get a just a second. No, sometimes you get a nerve, or not nerve, you get a root which is like this, and this part is going like this. Who knows how the root is? So you need to get the periapical region. Okay, you need to get the periapical region. If you get the periapical region, that's good enough. It's good enough. If you can get the full crown and the full periapical region, IOPA is good enough. Okay, only when you doubt something else, or you doubt some pathology, you can go for an OPG. So OPG gives you a very good view. Just have a look at it. For planning, OPG is really good. Why? Because it shows you the ramus, it shows you the inferior alveolar canal, it shows you the height of mandible. So you have the ramus here, you have the height of mandible, you got how much high it is, you have the inferior alveolar canal going. So for planning, this is the best, I believe. If you can get OPGs for all cases, well and good. But even if an IOPA will do, provided it shows the entire crown and entire root, tip till the tip. Now, this is one assessment all of you should know. Okay, this is one assessment all of you should know. Why? Now, the important one, I'm just marking the important line. This is the important line, that is amber line. It's yellow colored line. Now, why is it important? Now, I'll just simplify it for you. And I am marking an area which is red in color. Now, whichever area I have marked red in color is below the bone. See, does it make sense? Now, the area which I am marking green in color is the area which is actually outside the bone. Now, that's the significance of knowing how to mark your yellow line will help you. So I'm just marking the yellow line for you. So this is your amber line. So what is amber line? It represents the height of bone. So how do you draw it? You draw it from the ramus up to the anterior or the mesial area of your second molar. This is your second molar. So this line will actually tell you how much of how much of teeth is above the bone. So this is very important planning. And next important one in planning is your red line. So what is the significance of red line? Now, your elevator is kept at the CEJ. So how much of bone you have to cut? How much of bone you have to cut in order to reach the CEJ? That is measured by the red line. So whenever the depth of red line is, it's more deep, the difficulty is high. So that's the significance of red line. Okay. So, and white line is the one which represents your occlusal level. So I find amber line very important. Only when you start assessing the X-rays with amber line, you will get an idea of how much is below bone or how much is above bone. Or else, what will happen? Let me just tell you what can go wrong. So instead of marking your amber line, if you just look at this X-ray, you might feel that your bone level is somewhat like this. You feel like that. Okay, that's why you have to draw a line from this point upwards. So that will give you a clearer idea of how much bone you have to remove and how much is the difficulty of planning. Now, what about CBCT? CBCT is very good. It's very good. And most of the times I find it, most of the times your OPG is enough for planning, but CBCT will help you to communicate with your patient's bystander. Why? Because that will allow you to actually three-dimensionally show the patient bystander and patient that how much or how difficult this kind of impaction is, and how much effort you will have to put in taking it out. And if at all it's close to inferior alveolar nerve, you can just tell them that this is really close and there are higher chances that you will get a paresthesia. So for communicating with patients, this is a beautiful thing, they will easily understand it. Okay. So CBCT not for every case I take, but yes, if I feel it is very close to the nerve, CBCT always. Okay. So the assessment through CBCT, you can have, you can easily assess where the nerve is and where the roots are and the relationship. So you actually know towards which area you have to give force and which area you are not supposed to give force. So that's actually very helpful, Now coming to assessing the angulation of third molar, you always assess the angulation of third molar in relationship to the second molar. So second molar is the guideline, and you have to compare the angulation with second molar, and you have various types like your mesio-angular. This is a very, very simple classification by Winters. You have the mesio-angular, which is mesially angulated. Now you have the disto-angular, which is distally angulated. You have the vertical, which is, actually parallel to the horizontal axis of your second molar. Then the horizontal one. And then there are something called as bucco-angular and lingo-angular. Some authors call it as bucco-versed and lingo-versed. So it's like it is tilted towards buccal and it's tilted towards lingual. And rare ones are like the inverted ones. Okay. So these classifications are important for, and it's always easy for you to communicate with your colleague that it's a mesio-angular impaction, it's angular impaction. And it's easy for you to refer to the specialist, when it is a difficult, tough impactions like disto-angulars, horizontals, and all. Vertical is very tough. It may look very easy. It is very tough. Sometimes it won't come because you have to cut a lot of bone for it to move. So when you're referring to a consultant, it is easier for you to communicate. So you should know the basic classification. And also very important one is you should know the Bell and Gregory's classification based on space available. Now this level A is at the occlusal level. Okay. Now level B is slightly below the occlusal level, but not at the level of or not below the cervical level. Now this is the cervical level. Now level C is below the cervical level. So as the level progresses, the difficulty of impaction also increases. So that's based on the height or how much it has come out. Okay. Another classification also by Pell and Gregory is based on the Ramus relationship. So the available space here, they have calculated the available space between the ramus and the second molar. So there is a lot of space, you call it as class 1. Now, if the half of the teeth is inside the, or some part of the teeth is inside the ramus, you call it as class 2. If the entire teeth is inside the ramus, it is class 3. So as it progresses from class 1, class 2 to class 3, the difficulty also increases. So this is the basic classification. Now, moving on to your treatment part. Now, first you have to formulate a diagnosis, whether why you should be removing this teeth. Now, look at this particular teeth. Look at this particular teeth. There is no symptom for the patient. What will you do? Can you find out anything, any possible reason to remove this teeth? No. I told you that in X-ray, you should look for the follicle space. Now, this is the follicle space. This will be the follicle. Now, is it enlarged? No, it is not much enlarged. It is not enlarged. Yeah, it endangers 7. Somebody has said it endangers 7. So now I also want you to understand that you can actually see the soft tissue here. Can you see the soft tissue here? This is the soft tissue. This is the soft tissue of upper. Can you see the soft tissue? Now, can you see the thickness? Now, how much thick the soft tissue is? Now, I'll just erase the ink. Can you see the X-ray? See the shadow of soft tissue? Now, it has a thick soft tissue. Now, if you probe for a pocket and if you don't get a pocket, this is very, the chances for it to cause any problem is, very less. It's not actually causing any pressure effect on the 7 because there is no resorption of this cementum. There is no food impaction there. And the root has already, roots have formed. Now there won't be much of eruptive force hitting on to the second molar. So now, why should we remove this teeth? Any reason to remove this teeth? No, probably I would leave it because there is a good soft tissue covering over it and the patient is totally asymptomatic. I'll be like, we will check the X-ray like 3-4 years later, or whenever you get symptom, or whenever it's your next after 1 year or something, when you come for a review, we will check. So that's what I will be doing. Now, cyst formation, Rakesh has asked, what about cyst formation? So that's the first point which I said. See, look at the follicle. There is no enlargement to the follicle. Now I'll erase the ink. Just look at this follicle. There is no enlargement to the follicle. So that's why I am telling, we will take X-ray after 2-3 years. Why? Because the cyst formation will take a lot of time. So if at all he is symptomatic, we'll take an X-ray and see. If he is not symptomatic, we will wait. We'll wait for some time and do. Okay. So this type of teeth, you can actually put it under wait and watch category. Now, what about this case? Now, this will answer Rakesh's doubt. Look at the follicle. Look at the follicle here. This also is totally asymptomatic, but look at the follicle here. Follicle size is enlarged. Can you see this? Follicle size is enlarged. Yes. So that is one criteria which you should all understand. Follicle size is increased means, yeah, Aisha, you cannot call this as a cyst. You cannot call this a cyst. It's just evolving cyst. It has not become a cyst, but yes, soon it will become. So increase in follicle width, this width, see, if it is getting increased, that is going to be a factor which you should always check. Now, this kind of teeth, I will definitely take it then and there. I will not wait for, a few months or something. So that's one criteria. So look at this and look at this. So this second one, we have to remove because of the cystic lining or cyst being grown. Now, it's only a matter of few months or years that the cyst can become something like this. This is a big cyst. Okay, this is a big cyst. So that's one criteria which we should clearly, think about. Now, what about this teeth? Will you remove this one? That's also impacted. Will you remove? Okay, I'll just mark one with red color and another with blue color. Now just see the cyst. The cyst is actually developing from the follicle. Compare it with the blue, compare the blue with red one. Which one will you remove? It's very easy. You will remove only the red one and have a look at the blue one. Blue one is small. You don't have to remove it. Okay. So it's the same patient, same age, same similar eruption pattern, both sides. One side is cyst and another side you don't have cyst. Okay. So that's thing. Now, treatment planning. So what is so much to plan in impaction? So we will see the treatment planning part in impaction. Here, you have to decide whether you have to raise a flap or not. We have to talk about bone guttering. We have to talk about tooth sectioning. So there are so many things in planning part itself. Flap, bone removal, tooth sectioning. So that is different from the rest of the teeth. Rest of the teeth is pretty much simple. You get hold of some forceps, do buccolingual traction, and the teeth will come out. Yes. Now we'll move to the step of raising a flap. Why do you raise a flap? Here we need to approach the bone, and sometimes you will have to gutter the bone to remove the teeth. So to access the bone, you have a lot of designs. Very simple two designs which you need is the envelope and warts. So I will first draw you the envelope incision. Now, how do you do an envelope incision? There is a distal incision like this. There is a clavicular part to it, and there is clavicular extended slightly like this. Now this will become a short envelope. Now short envelope is very good for small impactions, level A, level B impactions. Okay, very good. Short envelope is enough. But if it is a deeper impaction, if you want more access, okay, listen to me. If you want more access, you just convert this short envelope into a longer one. So how do you do it? So you just extend it and include this interdental papilla. So if you extend it more mesial to the second molar, it becomes a longer envelope. So most of the times, envelope flaps are good enough for impactions. Now, what about cases where you need more access? Sometimes it is not enough for you to have just an envelope flap and just access the entire area of bone removal. So sometimes you want a better access, then you give something called as releasing incision. So you can extend this like this and you extend it downwards like this. Now it's a releasing incision. Now this has a distal limb, a clavicular part, and a mesial limb. So you have a distal limb, clavicular part, and a mesial limb. And now it becomes warts incision. So just imagine warts is nothing but a envelope flap with a downward releasing incision, which is slightly curved anteriorly as I have drawn here. And if you want more, even warts is not enough. If you want more access, what you go for is something called as extended warts. You just extend it like this here and then give a downward incision. That's all. Okay, so you have the normal warts or you have the extended, or some call it as modified warts. Okay, so these are the two incisions which you need to know at all. You don't have to know anything else. Why? Because this will give you access to all type of cases. And if you learn more at this beginning stage, it is difficult to comprehend. You can change your axis or change your pattern of incisions later on. Now, one important factor is distally, when you're giving incision, you give it slightly buccally angulated to avoid lingual nerve and some vessels in the lingual aspect. Okay, so that's one thing you should keep it mind. And releasing incision is given like this, slightly curved anteriorly in case of warts. And as a as a starter or beginner, if you're doing impaction, I would always suggest you to start with warts. Why? You will have a very good access. Good access is the key point to having a successful impaction removal. If you don't have access, it's very difficult. So warts will be my choice if I'm teaching someone to start impactions. Okay. Envelope is good once you know the area, once you understand the anatomy, then you can shift to envelope. Okay. And there are various schools of thought. Some say that if you have a releasing incision, the excess fluid will drain out through it and swelling will reduce and all. Swelling is more dependent on your applying ice pack, use of steroids, and also don't worry about all those things. You want to do or you want to learn in initial stages, it's always advisable to go for warts incision. Now, what about bone removal? Now, there's collarbone technique and postage stamp method. A very simple thing. How is collarbone technique? You have the teeth like this. And as a rule, you always remove the buccal bone. So this let be buccal, this let be lingual, and you create a ditch around the teeth. A small groove around the teeth. That's called as collarbone technique. Now this is an occlusal view. Okay, just imagine this is an occlusal view. Now, what about postage stamp? Postage stamp is when you want to remove more bone. What you do is from the side. See, this is your second molar, and this is your third molar, which is impacted. And this is your bone. Okay, this is the bone like this. Now, if you want to remove more bone, you just put, with your round burr, you just put this postage stamps, and then you join this postage stamps. And it is very easy now to remove this entire chunk of bone. One quick thing, and you will get the entire thing removed. So now the choice of collarbone or postage stamp depends on the depth of impaction and how much bone to be removed. So if it is a very deep impaction, I always go for postage stamp method. If it is not so deep, like it's level B and level A and all, collarbone technique is good enough. You can easily take the teeth out. But whenever you get stuck with collarbone, proceed to postage stamp, remove more of bone, and it will ease your access to the teeth. Now, coming to tooth sectioning. Now, tooth belongs to surgeon. Now, why? Because we are removing the tooth. It belongs to us, and you cut it to how much ever pieces. It doesn't matter. As long as you make sure that bone cutting is minimal. Bone cutting should be kept minimal. Why? Because the bone belongs to the patient. Bone is not owned by the surgeon. Surgeon can only take the teeth home, and bone is taken back by the patient. So you keep the bone removal minimal as possible and section the teeth as far as possible. Sectioning the teeth has a lot of advantages. Why? Because the force transmitted by your elevation to the jaw also is less when you section the teeth. So this is the tooth, suppose. And now you have gutted the buccal bone. Say collarbone technique is good enough. First point is buccal bone guttering. Second point is look at this area. Mesially, look at this area. Mesially, you gutter in such a way that you can keep a straight elevator. The elevator should fit into this region. So you can gutter in such a way that the elevator fits into that region. And then you can proceed and section the tooth. Now, once you section the tooth, deal it like two teeth. Remove the first teeth and remove the second teeth. Now, what do you mean by first teeth and second teeth? Now, you remove the distalmost one first, distalmost section part first, and then this part. Now, any other advantage? Yes, I told you that excess force and all will be there when you are trying to take the teeth out in a single piece. But another important thing is, suppose you are elevating in this area. The arc of rotation of teeth is like this. You're putting force like this to elevate the teeth. Arc of rotation is like this. So this root will come down. This root will go up when you're elevating. And when this comes down, it may cause a problem here. It may impinge onto the inferior alveolar nerve. which you don't want to happen. And it happens mostly in case of your mesioangular, similar case, which I've shown in this picture, because the nerve rise right down. So when you are excessively putting pressure, the teeth will rotate in such a way that the distal root will go and hit the nerve. So I don't want that to happen. So I prefer to section the teeth, remove this first and remove this second. Okay. So that's the best way to remove it. So the mesial area, and also distally, you should cut some area so that the teeth has adequate space to stand up. Okay. So this is how you do it. Now that was briefly about how you do it. Is there any difference in wisdom tooth removal and any other molar teeth removal? Any difference? I'll just show you the two differences. So this is the mouth opening at this level, and posteriorly the teeth is going, or the jaw is going to go like this, and the mouth opening decreases posteriorly. Obvious thing, everyone knows this. You know, mouth opening is going to decrease posteriorly. This will make your instrumentation more tough. Sometimes you will have to angulate your instrument and hold the molar forceps. That's one point. Okay. Another point is, can you see this? How many of you recognize this particular thing which I've drawn? How many of you recognize it? Can you name the structure there? What is that white line? What is that white line? This white line which I've just marked. This white line. Yeah, somebody has said it. Dr. Deepthi has said it. Yes, yes, external oblique ridge. Very good. So external oblique ridge is there, which is a great anatomical landmark when you are giving your IA and B. And just see this. Just see the area which I'm marking in white now. Okay, I'm just marking in white. I'll just yeah, the area which I'm marking in white now. Now this area, this entire area is called the alveolar process. Now alveolar process is a very thin bone. You put a forceps, you put buccal pressure and lingual pressure. This alveolar socket or alveolar process expands. That's how you take the teeth out. Now, just see, the alveolar process is going to be thin when it comes here. The alveolar process is now gone. Now the area is dominated by, from here onwards, it's dominated by the external oblique ridge. Now, this is one very important point which you all should know. This is the reason why when you use forceps and you give buccal traction, sometimes the crown abruptly fractures. Why? Because this area is not your alveolar process. This area is your external oblique ridge, and the socket doesn't expand in that region. So that's one thing which we should keep in mind. Normal forceps extraction might be difficult due to the limited mouth opening and due to this anatomical structure which can make it difficult. One more anatomic structure is the upper teeth, which can, you know, when you're giving buccal and lingual traction, upper teeth is obstructing. That is because of the mouth opening, limited mouth opening. Okay. So how many of you play cricket? I think majority, if you don't play cricket, at least you have seen people playing cricket, isn't it? Now, just a common sense thing, you know, there are a lot of fielders in this area. Will you prefer batting towards that region? You can see the ball going like this. But will you, as a batsman, will you bat towards this region? So many people are there. Will you like to bat towards that region, or will you bat towards the region which I'm marking now? Will you hit towards this side where the fielders are not there? Will you choose the fielders side or the area where fielders are not there? Quickly, tell me. Yeah, people, come on. Yes, no fielders. Yeah, others, you can message in the chat box. I don't want you people sleeping. Yes, no fielder zone. Exactly, Aisha. No fielder zone. So here is the fielder. Now, will you give more buccal traction, or you will try to give more lingual or distal traction? What will you do? Which area will you prefer now? Yes, exactly. You prefer more lingual and more distal area because that's where the fielders are not there. Your buccal area is filled with thick bone. You cannot expand it there. So you don't want to use that to advantage. So it's like this cricket match where you have more fielders. You don't want to hit the ball towards the fielder side. Okay. And that's when obviously that's how you may end up, getting out in cricket, and that same way you may end up fracturing the teeth. So this is a fielder here. Look at this. Look at this width. Look at this width. And this may be sometimes really strong. And I'm sure that many of you might have faced it, abrupt fracture of the crown when you try to put the buccal traction, because generally we do buccal traction for all the teeth. So here, reduce the buccal traction. You have to push the teeth more lingually and distally. Now, these are two accessories which you should have. Now, what type of forceps is this? Anyone knows what type of forceps is this? This is called as the American pattern molar forceps. Now, this is slightly different from the conventional molar forceps, and also the cow horn. These can be handy if you actually know how to use it in third molar extraction. I'll just show you the difference between the cow horn and normal molar forceps. Now, normal molar forceps may have a larger hinge, whereas this has a smaller hinge. Now, look at this angulation. Because of the shape of the normal molar forceps, it is very difficult to engage it in the third molar region. Whereas, due to the smaller hinge, this can be engaged more deeper in and easier to extract. Slightly flared roots. If the teeth has slightly flared root, it's easier to grab the CEJ with a cow horn and extract. So preferably you can use cow horn, but you should not use the excess force onto the bone. You should make sure that the force is fully on the teeth. If you put excess force on the bone may fracture. That's the problem with cow horn. Cow horn, you have to be judicious in using it. And now this is the difference between the molar forceps. Just see the American pattern and the English forceps. So the English forceps has one disadvantage. It comes from buccal side. If you want this kind of orientation, you will have to cut a hole in the cheek and you have to put a forceps, because you cannot get this perfect 90-degree to the long axis of teeth. You cannot get it. Why? Because you have the cheek obstructing it. Whereas when you look at the American pattern forceps, the design is such a way that it comes from anterior, it comes from the front. So American pattern forceps is much reliable one when it comes for third molar extraction. Now, can you recognize these people who are playing football? Sorry, cricket, not football, cricket. Can you recognize both of them? Very easy people to recognize. If you can recognize one person, you will recognize the other person also. Yeah, Tendulkar is there and Ganguly. Very good. So why I put this is, a long innings and a long day of cricket is never won by one person alone. You have to rotate your team. You have to rotate the batsman. Both of them were very good partners when it came to scoring runs. These people were good partners. The bowlers also will have a disadvantage when they get two batsmen, instead of one person striking the 6 balls. So similarly, when you're doing extraction, never be a person who uses only one instrument. Why? The limitation and the way a single instrument can be used there is a lot of limitation in which you can use a single instrument. So to counter that, you should have different sets or different types of instruments for extraction. So I'll tell you why and I'll tell you how. Now, when you have a molar forceps, you can apply force buccally and lingually. You cannot apply force distally. But when you have a elevator can push the teeth distally. So when you use it like in combination, when you try with cow horn, teeth is not coming, take your elevator, try to luxate the teeth, push it more distally. If it is moving slightly, then come again, take your cow horn. So keep rotating your instrument as how these people will rotate when there's a difficult or very, very fast bowler bowling at them and they cannot score much runs, they keep rotating their position, from runner side to the batsman. So similarly, keep rotating your instruments and that's going to help you a lot. Now we'll move to bone removal part. How do you remove bone? So there are burrs which is used, and you should also know the length of the burr. Now I'll just show the length and I'll come back to the slide. Now what I mean by length here is this length. Okay, it is somewhere around 7 mm. Why? Because every time when you're cutting the bone, you cannot use a perio probe or something and measure how deep you have gone. So you should know a rough idea of how much is the length of the cutting edge. And now there are various types, like when you are going for impaction, there are 701, 703, 702. So 1 is small, 3 is large. So 1, 2, 3 here represents the diameter, and mostly I prefer 702 because 3 is slightly bulkier one. 1 is very small, 1 may fracture. It fractures at this end, which I don't want to happen. If it fractures, it's difficult to retrieve it out. So I prefer for 702. 703 is slightly more bigger. I don't want a big burr also. And another one is your round burr. This is very useful for your postage stamp and all. So it also comes in 3 sizes. I prefer 8. 6 is small. 12 is slightly larger one. You don't need such large ones. So the ideal length is 7 mm, diameter around 1.5 mm. You have a rose head burr or a Fisher tape burr for gross removal. Both the burrs I have shown the picture, and it should always rotate in correct direction and maximum speed. Maximum speed is the best. Don't go very slow, because very slow is going to reduce the cutting efficiency. It's going to generate more heat. So we don't want that to happen. We want best cutting efficiency. Okay. And cutting instruments that induce air should not be used, like your air rotor. I'll talk in detail about air rotor later. Okay. And handpiece, make sure that it is not touching your lip and all, because some of the people end up cutting the lip, or the heat generated due to the rotations may cause lip burn. So you need to avoid it. So don't keep it resting on the cheek. Now, a very interesting fact about your irrigation is, all we want to make sure is the area remains cool, no heat generated at all. So that's what we want. So we want copious irrigation. We want continuous irrigation as good as possible. The area should be always wet, and it doesn't matter what type of irrigant you are using. It can be saline, it can be sterile water, it can be ringer lactate, it can be povidone. All of these doesn't have any advantage over the other, except that if you are using a colder saline, colder sterile water, that has advantage. Now, any of these which are friendly to the bone and soft tissue can be used. And only thing is, if you are using saline, you can put it in the fridge and you can use cold saline, because cold saline will make sure that the area is more. We don't want the heat to be generated. So cold saline will make sure that the area is not generating much heat. And if heat is generated, that will multiply your swelling, post-operative inflammation. Okay. So that's the point to remember from irrigation part. Now let's move to some cases. Now this is a problem with recent days X-rays. Why? Because the not recent days X-ray, I would say that the ones which has the bulkier sensors, you might not be able to place it more deep. And if you're placing it deep, the sensor is small. Sometimes it cannot take the entirety. So you take 2 projections like this. This is the same teeth, 2 projections. It's the same teeth, and you can have a rough idea of how it appears when you superimpose the picture. And this might be the rough position of the teeth. Okay, and then evaluate for the nerve. Where is the nerve? This lower part is the nerve or the canal, and the upper part will show you the bone level. Okay, and then start planning. So I'll just ask you, this is not a very deep impaction. It's somewhere between level A and it is level A. It's not level B also. So can you say which flap you want for this? Which flap do you prefer for this? Anyone? Which flap do you want for this? Yes, warts can be good, very good. Warts can be done, and envelope also can be done. So I think I had preferred warts in this case. So now this is your warts. This is how you plan. And only thing you have to be careful is the releasing incision. This is your releasing incision. That is your mesial limb. Should not lie on the area where you're cutting the bone. If it is so, you have to extend the warts and go for modified warts. So that is one point, important point to remember. Never, this line should never lie on the area where you're cutting the bone. So this is the flap which I have planned here. This is the clinical view of it. Now I'll just show you the incision. Just a second, hold on. I'll just share the video of incision. Yeah, I hope the screen is shared now.
Yes.
Yes, it is, sir.
So I'll just play it for you. Just see how the incision is. As a rule, we prefer to give the incision from distal towards mesial. That will give you more control, except for the releasing incision. Releasing incision, you give it from your vestibule towards your teeth. Okay. So just have a look at the video. So I'm making sure that the incision is slightly buccally curved. Now I'm giving the clavicular incision. Yeah, I'm giving the clavicular incision now, and now the releasing incision. I'm coming from down upwards because I don't want to extend it by mistake. If I go downwards, I may extend it through the vestibule. I don't want that to happen. And generally, I don't use mouth mirror to retract. I use I retract it with my thumb. But for the purpose of showing the video, I have just retracted it with my mouth mirror. And now I'm using the periosteal elevator, and this is how I raise the flap. First, I undermine the flap, and then I go to the internal papillae in the mesial most area, and I roll the papillae out. I just roll the papilla out. Now suction, I prefer to use the soft suction, and you can either disinfect it with a Dettol solution, or you can use a glutaraldehyde solution. The metallic suction is good, but the assistant should make sure that metallic suctions are not hitting to any other part of your mouth. So this soft suction which you use for saliva is good enough for most of the cases. So this is how you raise the flap. Now I'm using the cotton to clean it. See, I'm Raising the flap now. And I'm making sure that I raise adequate so that I have enough room to cut the bone. So this is the flap which I have raised. So you can see the bone. You can see how much far I have kept it so that I have adequate access to the teeth. So this is the, I hope my screen is now shared.
Yes, it is, sir.
Yeah. So this is the, see, this is the amount, or this is the width of flap which I've raised, or the amount of bone I can actually see. This will allow me for ease of instrumentation. So the common mistake people make is they raise a very small flap. And when they raise a very small flap, when they're cutting the bone, sometimes what happens is the burr is going to abrade over the soft tissue, which is going to create more post-operative inflammation. So you don't want that to happen. So retract the flap away from the area. Now this is how I've gutted the bone. Now this is a cervical collarbone technique. I've just gutted the collarbone alone. Okay. Now this is the external oblique ridge here. I've just gutted the collarbone very close to the teeth. Now, I also need to do tooth sectioning. So we will see how tooth sectioning is done. Yeah, now after. I hope my video is seen now. Now the tooth sectioning, I have sectioned the tooth, and now I use a straight elevator. I put the straight elevator and I put the tooth.
It's not being shared at this point, sir.
Just a minute, just a minute. Is it shared now?
Yes, it is, sir. Please proceed.
Okay, fine. Thank you. 1 second. Yeah, see the groove which I have made. I've made the groove in the buccal aspect through the, there is a buccal groove in the teeth, and I've extended the groove with my burr, and now I use a straight elevator and I section the teeth. Now my sectioning with burr is not continuous, or it's not through and through. I ensure that the lingual side is not cut, and then I'll use my straight elevator, and then I will section the teeth by wedging it. So this is how the socket looks like. You can see the periapical regions. Okay, this is how the socket looks like. This is the interradicular bone. This is the buccal part which I've actually gutted, and now I smoothen this area with a bone file, and then I proceed to suture like this. And see the incision line here, the curved incision line in anterior part, releasing incision. This is the Watts incision. And when your incision is proper, it will close, it will approximate on its own. You don't have to suture in that region. Okay, so that's one thing which you can keep in mind, and make sure that you leave adequate thread. At least 8 mm of thread you leave, or else it's very difficult to do suture removal for third molar. So this is the teeth which I have sectioned and removed. Now, can we use air rotor for impactions? Quickly, anyone? Can we use air rotor for impactions? I want your view on that. Yes, no, yes. I'm getting mixed opinions. Okay, good. So generally, any air rotor which lets out the air, air rotor which lets out the air, that the turbine will rotate and the air will come out, cannot be used because it causes something called as surgical emphysema, which may lead to air embolism. But there are surgical aerators. Now, what is surgical aerators? This is one such surgical aerator. It is having a 45-degree bend, and this can be used. This can be used. Why? Because the air doesn't come out. It rotates the turbine and it goes back. So air is not being sprayed onto the area where you're cutting. So this is one teeth I'm showing. This is a minimal impaction. Okay, this is a minimal impaction. What I have this surgical handpiece. So what I felt is it is not very easy to do deep impaction with this. But yes, bone removal you can do, everything you can do. But yeah, just have a look at it. See, the advantage is you have the irrigation inside, you have the light source there. So you can cut the bone there, and I can. I hope it's seen, and is the audio being heard?
Sir, the audio in the video is not audible, sir, but we can hear you clearly.
Once I'm trying to play it again. Yeah. Now, can you see? There is only water coming out. Can you see? There is only water coming out. There is no air coming out. If air was coming out, the water would be actually what do you say, splattering. So there is no splattering happening, and this is a short envelope flap, and I'm now cutting the buccal bone. And this is actually my student. She was very uncooperative. Now see the sectioning. See the sectioning. I've done already the buccal guttering, and now I'm doing the sectioning. And later I did the same way. I used a straight elevator, and I then split the tooth and took the tooth out. So the tooth sectioning was done. And what else can we use to cut bone? Anything, any other instrument, you know? I'm not talking about chisel and mallet at all at this point, because that's one of the most traumatic instruments to patient. Trauma is mental here, okay? Not physical trauma, mental trauma. You may be able to chip the bone very easily and take the tooth out, but it remains in his mind, you know, throughout his life, that this doctor has used a hammer and he was hammering onto my face. So yes, very good, Dr. Deepthi and Dr. Shivakumar. We can use something called as piezo surgery. Now, what is piezo surgery? Any person who has done a scaling will understand what is piezo surgery. It is an ultrasonic device which along with electric this thing impulse, it cuts mineralized tissue selectively. So for ease of understanding, I'll just compare it to completely to a scaler. Completely to a scaler. When you use your scaler on tongue or something, you cannot cut through the tongue. You may be able to irritate it, but you cannot cut through it. But calculus, yes, it will remove the calculus, isn't it? So similarly, your piezo also can cut the bone. It can cut part of teeth also, but it cannot cut soft tissue. It can cut only mineralized tissues. So in a way, this is good to reduce the soft tissue damage, but it's slightly slower and the unit is expensive. It can be anywhere from 1.5 to 3 lakhs. So that is one thing which you can use. It has tips like this. It is almost similar to your scaler. The same way you open the scaler tips and put the another insert. Similarly, here also you can put it. And advantage is the water is there, light is there, and swelling is minimal, and patient compliance is better. Okay, but it takes a bit longer time. This is like the case which I done with piezo. So there's an impacted teeth inside. Now, can you see the flap here? Can you see how much visibility you get? So this is the only portion of teeth which is out now, which you can relate in the X-ray. So now this will be the yellow line. See, this part will be the yellow line. I'll just draw the yellow line for you. Then you can go and look at the picture. So this will be your yellow line. Okay, somewhere like this. So what? I'll draw it again. Just this is your yellow line. So whatever portion below the yellow line is inside the bone. So let's have a look at that picture, clinical picture. See, can you relate it now? Now, can you understand why I was talking much about yellow line? See, this is the only part of teeth which is outside the bone. And we use the piezo. Now see, the light is there, water will come, and yes, it is good to cut bone, but not very efficient to cut teeth. I have used normal micromotor burr, and this is your long envelope flap which I have raised. So the first molar, second molar, third molar, long envelope flap. This is a retractor called as Austin's retractor, which is very useful when you're doing impactions. And this is the socket, and this is the suture after it, okay, after we have removed the teeth. Now, always use bite blocks because it will help the patient. Patient doesn't have to, or else they will get fatigued when they open the mouth for longer time. Now we will quickly see some difficult extractions. So sometimes you get an RCT treated teeth like this. It fractured, of no reason of yours, and now patient wants to go for a replacement. He has to get this teeth removed. So this kind of teeth is very difficult. Sometimes you will have to cut a small amount of buccal bone, remove one root. Sometimes you will have to section the roots on top, remove one root, then remove the other one, remove the third one. Now this is the 3 roots itself is difficult in lower molar. So this might be the way to remove a fractured root canal treated tooth, or else if you're using just your forceps, it may chip off and it's very difficult to extract. Another type of case which is very difficult to handle is isolated tooth. So isolated tooth, to make it easy, you can cut bone in the mesial area. Why? To create a space to put elevator, and don't use excess force. If the teeth is not coming out, cut buccal bone also, create a space in buccal area like this and try to remove the teeth. If it doesn't come, or if you don't want to do like that, you can always split the tooth like this in center, and now you can deal it as 2 tooth. Split in center, remove one segment like this, remove another segment like this. Okay, so however it be, make sure that you're putting less force onto the bone and onto the teeth. With minimal force, the teeth should come out. Another type of case is any fractured root piece. First thing you should do is put a K file inside it. Why? Pull the K file, that root piece will come out? No, the root piece will not come out when you pull the K file, but it will at least give you an orientation where the root piece is, and it will give you an access, or it will give you a handle to pull this out by using some other elevators. If you're trying to luxate the tooth, you can use this K file and take it out. So only thing is, in some cases, if the root piece is mobile, you can put the K file directly and you can pull the K file, the teeth will come out. But otherwise, engage the K file, create a space in the bone with the burr. See, in this one, I'm creating a space like this. Now I can put an elevator in that space and luxate and take the tooth out. So that was some way to remove the some difficult extractions. Now we will just move to few complications before we wind up the session. Very simple complication. Not all complications I'm covering. I'm just telling you the common complications like bleeding, paresthesia, swelling, hematoma, and dry socket. Now, patient will come sometimes with this scenario: 5 hours post-extraction, bleeding from oral cavity. What could have gone wrong? This is a nightmare for any surgeon. Patient coming back to the operatory, bleeding. But trust me, if you make sure that the bleeding is arrested when you have sent the patient, then probably you can, there is no other much cause, and you can cover the patient, or you can correct the problem in the next visit also. Next visit, like patient has come after 5 hours. So let's just analyze things to make sure that where things have gone wrong, First, ask whether he or she has followed the post-op instructions. Recheck his medical history. He would have hide some fact. Blood investigations, if required, you can send for BTCT and CBCPT INR. You can send, and you should know some surgical methods and medical management to control the bleeding. Now, very common thing, post-op instructions. Every single person is going to say, "Doctor, what you said, I've done everything." But when they go home, this will be the scenario there. Okay, we would have told them not to spit, and this will be what they are doing. So sometimes the cause can be very, very small thing. They would have, the bleeding would have started because of their excess pressure or the way they have handled the situation. They have been spitting all throughout after extraction. Yes, bleeding will be there. And another thing is, make sure that the pack, the cotton pack which you place or the gauze pack which you place should be comfortable. Now, this is very uncomfortable to have a very big pack. This will end up patient salivating more, and they will tend to spit out saliva. So that itself can cause bleeding. So we want a very minimal pack in a way that the mouth should be closed. And every extraction, make sure you give them ice pack. Ice pack, when you're giving, tell them to apply it at least 15 minutes continuous and take away for 5 minutes. Again, 15 minutes. Take on and 5 minutes off, and continue the cycle. Okay. Check for any history, antiplatelets, blood pressure, and all. Then surgical method is putting a figure of 8 suture, and you can put something like gel form inside the cavity, and you can suture it to control bleeding. Medical management, you can always keep this etamsulate 500 250 mg and Tranexa 500 mg tabs in your clinic. And how to use it? You can either put it squish. You can put it in water and tell them to swish it in the mouth as an oral rinse, or you can make it into small powder, keep it over the cotton pack, and keep it over the teeth. So that way you can use even injection. Also, you can use it in local application. Like, you can open the ampule. You can put it over you can soak the gauze with this injections, and you can put it as a local pack. That's how you generally use. And you can even take it orally. Etamsulate can be taken 250 mg twice. Tranexa can be taken 500 to 1 gram thrice a day. So this is some medical management for, this is all for mild ooze which comes out from the gingiva. Okay, not for sudden blood pumping out. Okay. So another one common thing is, swelling, post-operative swelling, and a swelling which has a change in color, which is suggestive of a hematoma. Now, what can be wrong in hematoma? So what could have gone wrong is, sometimes you don't tell the patient to give ice pack and all. You just give a cotton pack. And what will happen is, you have given a buccal traction. There will be minor crack in the buccal cortex, and that will lead to a bleeding which is inside the soft tissue. It is not coming outside the soft tissue, and it tracks all the way up to the skin, and there will be swelling and associated color change. So ensure that you tell ice pack for all patients. Now, if there's a hematoma which has come, you should understand it's self-solving. It will take 3 weeks of time. You can start with mild heat application, allow some functional movements, and antibiotics should be given to prevent infection. Okay. And this is another case, which is your dry socket, very common. Now, third day, if any patient calls you on the second and third day, usually on the third day, they'll say that I give anti-inflammatory and analgesic for 3 days. So when they call you at the third day and tell that, doctor, I'm having pain, don't just prescribe them analgesic. Call them to the operator. Third day, it's very important. Have a look at it. Most of the times it's dry socket. I've got dry socket in cases where I've done very simple extraction. When the extraction goes simple, the post-operative instructions are overlooked. They don't tend to follow it properly. So make sure that you give proper post-operative instructions. Tell them not to vigorously rinse. Tell them not to smoke. All those things may lead to the clot being dislodged. So once it happens, one patient comes with dry socket, just apply this beautiful product, Albuogel. You apply it. If you don't have Albuogel in your country, in your state, you can just mix a eugenol in a gauze, just in a gauze, and put the gauze inside the socket. first day you may have to give local infiltration when you're putting. And if it is a eugenol mix, you should take it out after 24 to 48 hours and replace it once more or twice or 2 times, so that the proper healing takes place. And most of the times you don't have to give antibiotics and analgesics at all. So Alvegel is one beautiful product which you can use. Now, how to prevent this? One way is make sure that the area is clean. You have not damaged any soft tissues there. Heart tissue also, you have addressed the heart tissue with respect. Make sure that you have not cut excessively and all, and then give a tight closure so that the clot doesn't get dislodged. And the final case to discuss is a case where you have a paresthesia following an impaction. So it can happen. There are two scenarios which can happen. One is on the lip and another one is on the tongue. So I'll just tell you briefly what happens when the teeth is impacted. So when the teeth is impacted, this is the normal teeth. This is a mandibular third molar and this is your canal here. When the teeth is impacted, impaction means the teeth, the root is somewhere around, the root comes further down, somewhere around this region. Now, when the teeth is impacted, say this is the impaction. Now the root has come more closer to the nerve. When the impaction becomes more deep, the root is more closer to the nerve. So the root is closer to inferior alveolar nerve. And like when I was talking about mesioangular impaction, when you put excess pressure on the mesial area, the distal root may go and hit the inferior alveolar nerve. So it may cause paresthesia. To avoid that, make sure you properly section the tooth, use minimal force. And whenever it is a tooth which is very close to inferior alveolar nerve, as far as possible, split the tooth and take the tooth out. Now, another scenario is the lingual nerve, which is in the lingual side, sometimes travels way too close to the crown of third molar. Now, here the crown is in relation with the lingual nerve and root is in the relation with the inferior alveolar. So here I had said that when you're giving incision, now this is a clavicular incision. Now this is your releasing incision and distal incision, you don't give it straight, you give it slightly buccally curved. This is a top view, okay, occlusal view. So distal incision, you give it slightly buccally curved to avoid the lingual nerve, okay. Also, it avoids retromolar vessels in that region. So that will give you a much bloodless feel. So most of the times when it comes to inferior alveolar nerve, it is neuropraxia, just compression of nerve. And this may recover. This may recover, but it will take long time. But in case of your lingual nerve, most of the times it can be due to, may not be just compression. It can be even a cut of the nerve because sometimes your instrument slips in that lingual area and it may end up damaging the nerve. So, reversal of a lingual nerve paresthesia is much difficult than a inferior alveolar nerve paresthesia. Okay, so it may take around 12 months to 18 months. Generally, we say that 15 days to 3 months is the initial period when it is going to revert back. And also, you should always give the patient vitamin supplements. Any vitamin B complex can be given over a period of 2 to 3 months.
Hello, sir. Dear doctors, sir is having a problem with his connection. He'll be back soon.
Yes, sorry about the connectivity issue. So we were at paresthesia. Yeah, I was talking about the vitamin supplements, which has to be given at least 3 months. 2 to 3 months you can give it. So now the session is open for discussion. So I have completed a few important topics in extraction or wisdom tooth removal. Now, can we open the session for discussion?
So thank you, sir. So it was indeed a wonderful session. So now you guys can post your queries in the chat box.
Now, those things which I have missed, no audio. Audio is there. Audio is there. And now those things which you have which you wanted to ask, you can ask now.
You can post your queries in the chat box. So Dr. Deepti have a question, sir. Alvosyl application clinically.
Yeah, clinically, you can keep it there. It's natural fibers. It will just disintegrate on its own.
So Dr. Deepa, which steroids to advise?
Steroids are always better when you give it prior to the surgery. You can follow the protocol that you can give it 1 hour prior to the surgery. And yes, followed by steroid on the same day, night, and next day. That's all. It's always better to start it prior than starting it after impaction.
Another question from Dr. Abhiram. Also, can we use bone graft for a better healing protocol?
No, rather than bone graft, I would suggest you to see bone graft itself is a foreign body. You can use it. You can use it for the healing purpose. But if you want to use, you can use PRFs. PRFs are really good. There's no point in putting a bone graft in third molar region because you don't want a quality bone to generate there. Why? Because you're not going to place an implant. So you can just give a PRF, and that itself will decrease your post-operative sensitivity in the 7 region, the second molar region. It will accelerate the healing there. There is no issue of clot dislodging. PRF itself is a clot, so there is no point of getting a dry socket. So there are a lot of benefits when you go for PRF. Graft you can do, but what's the point in doing a graft? You don't want a better quality bone to place implant and all. Anyway, bone will heal. It doesn't matter if it shrinks in size and all. If you want to reduce the size, reduce the shrinkage and all, then you can go for socket preservation. You usually do socket preservation with grafting in other teeth which is anterior to the third molar, not on third molar.
Okay, thank you, sir. So the next question from Dr. Aisha. So what about maxillary molar? What if it is close to the floor of the antrum?
Yeah, obviously it will be close to floor of antrum. You have to remove it when it's impacted. It's going. See, just like how the lowers are closer to inferior alveolar canal, this upper will be closer to the oroantral or the antrum. So to avoid oroantral fistula, you don't use excess force. You make sure you cut delicate bone in the occlusal region, and you take the teeth out. If you don't cut bone, if you put excess pressure, there will be a crack in the buccal cortical plate, or the distal retromolar area might fracture. So that will open up the orandral fistula.
Thank you, sir. So the last question for the night, sir. Other than lignocaine, what can be used in periapical abscess?
Other than lignocaine, what can be used in
periapical abscess?
No, I'll tell you what happens when you're using lignocaine in periapical abscess or any local anesthetic agent. The abscess is acidic. So when you are giving an LA, which is more basic in nature, what will happen is the diffusion of local anesthetic agent into the nerve is less. So what you can use is you can actually use more solution of LA, or you can wait for the periapical abscess to come down a bit. You can give antibiotics and you can do the procedure after 3 or 4 days, or you can use articaine, which has a better penetration than your lignocaine. But definitely, if you have an abscess there, you drain the abscess either through an access opening, or if it is buccally, it is obliterated. You can give an incision buccal, drain the abscess, wait for 3 days, give antibiotic coverage, and then go for the real procedure. Or else there's no point in injecting, or no point in trying to give a block in an area where there's a lot of abscess and trying to remove the teeth. Okay. So the anesthesia might not be effective efficiently there. Okay.
Thank you, sir. Thank you all for the overwhelming response. All the queries will be answered. You all can feel free to message us on our WhatsApp, or you can just mail us. All the queries will be answered. So once again, thank you, sir, for being with Online Dentistry. And
I'll just end the session with few slides on me. And I am Dr. Pravish, MDS maxillofacial surgery. I'm from Calicut. This is my guide. Presently, he is the principal of GTC Calicut, Dr. Soumitra. And I am a faculty in various forums. We have a entrance coaching facility online, which is called as Focus. Then these are a few of my cases, apart from minor oral surgery, reconstruction, and orthognathic surgeries. And I am also a faculty at Dubai for oral surgery, and this is my recent session in last February at Tumbe Dental Hospital. Apart from that, I am into sports and athletics. I represented my state Kerala many times. Some other passions are toy photography, and that's all from my side. Do feel free to get in touch if you have any doubts. And that's all for today. It's been a long night. Thank you all for active participation.
Thank you, sir, once again. So stay tuned till the next session on the second Wednesday for another